I want to kick off briefly with just telling a little bit of story about our organization's use of an RCT, what it was like to do the RCT, and then we completed our RCT, what it was like to work through the results. So I'm a family doc by training. I was running previously the Camden Coalition of Healthcare Providers, located in Camden, New Jersey, a small community-based nonprofit organization working together with local hospitals, primary care providers, and community residents to improve the quality of care across the city. We launched an RCT to test our model that was a care coordination, care management model focused on high-cost, high-complexity patients that have high both medical need and social and behavioral health needs. I'm sorry, I'm in Manhattan, and there's lots of ambulance sounds and background noise there. So the model was to meet people right at the bedside and to stick with them for up to 3 or 4 months and navigate them through local services. These were often patients who had and were identified with 2 or more inpatient visits. We launched an RCT because the entire field of population health and care management is filled with claims of impact and claims of savings and outcomes, positive outcomes for patients, but very few of those models have actually been tested in any rigorous way with a randomized controlled trial. And most of the publications that are out there are using weaker methods of observational data, pre-post, or propensity scoring. And as you heard in the last presentation, those can really mislead you in how you think about outcomes. So we were committed very early on. We received a CMMI grant to scale our model, which was going to enable us to have a big enough N to test it. And built into the CMMI funding was supposed to be an evaluation, but the intended evaluation that CMS was going to do was really going to just be propensity scoring. So knowing all the flaws with that and the amount of work it was going to take to scale up our model, and kind of this unique historical moment to have a federal CMMI grant, we were determined to do this rigorously and test it rigorously. So we reached out to Amy and to the JPAL team, and we did not have the internal resources nor the local partnerships that would have enabled us to do an RCT. A clinical RCT is complicated, and there were many reasons we would have never been able to pull this off ourselves. So the JPAL team was able to bring the sophistication, the resources, the know-how, and at many different levels, getting through the IRB process, creating the appropriate consent, making sure we've got the translation of the consent, the training of the team and the staff, and the very detailed workflows. We were using HIE data and hospital data to meet people right at the bedside, and the kind of gold standard for care management models is to actually randomize the patient at the bedside. What that means is that a staff member goes in, consents the patient, explains the work, then walks out and randomizes that patient, and basically randomizing them to default care. If you can imagine, you hire staff who are idealistic, staff think that our work helps people, so we'll walk out of the room and randomize either into default care, which we all thought was broken, is pretty hard to do. Managing all of the data and the study data was complicated as well. So it turned out, it was almost like holding bake sales to gather all the funding. There was nothing kind of built into the grant to pay for the research with JPAL's help. They and we were able to kind of raise the outside funding to keep the clinical trial going. It took us a couple of years to do it. There were lots of kind of complex hiccups along the way. And the result that we learned was that our RCT was negative. And we did our primary endpoint, and we purposely kept the RCT very simple. We did not, while we collected lots of data for our CMMI work, we didn't want to overly complicate the RCT because I just thought we were going to grind ourselves to a halt. I wanted to keep the messaging simple, the study simple. So our primary endpoint was cost and utilization reduction. And much like many of the rigorous studies that have been done in care management, we did not lower utilization, did not lower cost. And our analysis afterwards was that navigation to nowhere doesn't improve outcomes, or navigation to care models that are not trained and equipped to deal with people with significant trauma is not going to change their outcomes. And that in Camden, we didn't have good housing resources, didn't have housing first. Our addiction resources were not very good. They were not evidence-based. Our primary care providers were not trained nor equipped to deal with the most complex patients. That just navigating people to the default system was never going to change the outcomes. And it's really impacted my career significantly, impacted the organization. I'm currently, I've just started a new job. I'm on day 3 of working in Manhattan for a very large mental health and social service agency, because I think the kind of message I took from the RCT is the need to dramatically transform the way that we bring primary care, mental health, addiction, and social services to the outliers, the most complex, that frankly, none of these systems are doing a good job with these patients. So let me wrap up and we can dive now into the panel. The RCT was both professionally meaningful and organizationally meaningful. I think is transformative to the field, and really critical that we ask rigorous questions if we're going to move knowledge forward. And I believe this RCT moved knowledge forward. I believe the RCT you just heard about really helps to put a clear messaging down about workplace wellness models as well. So why don't we pivot now to Allison or Dr. Bulger? I'm not sure who's going to speak for you guys, but give some introduction to your model. Folks are going to hear about 2 different models and 2 different RCTs that are in the midst now of being put together. So Allison or Dr. Bulger, let me pass it over to you.
Yeah, thank you, Jeff. And I'll give a overview here of the program. Just real quickly, for those who aren't aware, Geisinger is an integrated delivery system. We have 10 hospital campuses, 125 clinics. We have a school of medicine, an innovation institute, and also an insurance plan. So it's a really great opportunity for us to be able to leverage those assets and resources, to be able to pilot and try programs like the Fresh Food Pharmacy, which I'm going to tell you a little bit more about. So we've always valued innovation at Geisinger, and 3 years ago, we started a journey to really think differently about how we treat type 2 diabetes, specifically using food as medicine in our food insecure patient population. So how did we do that, and how did we get started? We first looked at that population. We heat mapped where we had patients with a high prevalence of uncontrolled diabetes and overlaid that with some state data and other readily available data that showed where we had high rates of food insecurity in our footprint. And from there, we really developed a program that has 5 core pillars to it. And again, this approach was to, because as a healthcare organization, we had put a lot of effort and a lot of resources, frankly, financial and human resources into diabetes care, but weren't seeing necessarily the outcomes that we had hoped. And that was the kind of aha moment for us, where we took a step back and said, what if the patients that we're treating don't have access or the opportunity to get the foods that they need to be able to have meaningful change to their health? And so that was kind of where those 2 things collided. So the 5 pillars of the program that I think are important to note, the first is the identification of the patients and the referrals. So really understanding who the patients are. We had to embed food insecurity questions into our EMRs and into our workflows to try and collect that data on every patient who comes into the organization. And then relying on referrals from our providers as well as community. We rely on referrals actually from other participants who've been in the program. So it was really to try and understand where we can identify the patients, and also how are we going to measure the impact. And I think that was really an important piece of our strategy. The second pillar that's really important is the food provision. So we actually built food banks. They're run and operated by Geisinger. We have 3 locations, one urban in a food desert, one that's more rural and it's connected in partnership with an FQHC, and then another one sits right on our hospital campus in another area of our footprint. And Our smallest is about 2,000 square feet. Our largest is 5,000 square feet. So it's a pretty good sized facility. It's set up like a grocery store where individuals can come in. The difference with our food bank compared to some others is that we only offer healthy and nutritious items. We have a registered dietitian who approves all the food that comes in there. And the food provision is significant. It's 10 meals, enough food for 10 meals. They're not pre-cooked meals. You come in and shop, like I said, just like you would in a grocery store, but it's 10 meals a week. Every week for not just the patient, but their entire household. And we feel like that's a really important component of this program as well. So we made sure that that food provision could really impact the entire household and then transform the community as well. The third pillar that's really important is the education. So we wrap those participants with care team members, registered dietitian, a registered nurse, a community health worker. It was the same education and resources that we had available in our clinics. We just moved their offices and put them right on site with the food. And so as those participants came in to get their food, they also got the education, and we introduced an evidence-based program. We use Stanford's diabetes self-management program as part of a requirement. And we have seen dramatic results. Those who participate in the program actually reduce their hemoglobin A1C by about 1 point more than those who don't. So the education is a really important pillar. The fourth piece is the community partnerships and making sure that we're partnering with our Central Pennsylvania Food Bank, who's part of Feeding America, or other food banks in the community. Partnering with other local community resources is really critical, especially for our patients, because the fifth pillar is really that it's care beyond diabetes. And many of our patients who come in are not just dealing with food insecurity, they're also potentially dealing with transportation issues or other issues. And we were kind of naive when we started this journey, and really we're focused heavily on food insecurity, but recognized very quickly that there's often other social determinants that our patients are dealing with, and needed to make sure that we were able to address those as well. So those are kind of the 5 pillars that are really important and critical to the program. And we've seen consistent and demonstrated impact. And again, when we talk about the measurement, I'm just going to kind of end with a success story here. We have a grandmother who just recently graduated from our program. She was one of our first pilot patients, and Joe probably has heard about her, but she was one of the first 6. She's a 55-year-old grandmother. She's raising her 3 grandchildren, and was probably very hesitant to enroll in the program. She had been guided by her physician, and we tried to get her engaged, and it took us a little while to get her committed. But once she joined, she really became actually a really positive spokesperson for the program. She entered the program with hemoglobin A1C of 13.8. So she had been running double digits and in that range for an extended period of time, not able to take care of her own health because she was busy raising her grandchildren. She was 181 pounds. Her LDL was 209 and her triglycerides were over 300. So, quite a few things to work on. And after being in the program, within 6 months of her being involved, she saw significant reductions. Her hemoglobin A1C went from that 13.8 down to 5.4. And she retained a hemoglobin A1C less than 6 consistently for the duration of the program. She's been in the program just over 2 years. And so also was able to lose about 50 pounds as part of the program. Her LDL went from 209 to 47. Her triglycerides went from over 300 to 76. And she just recently graduated from the program. She's never graduated high school, so we threw her a little virtual cap and gown ceremony for her graduation. And she was thrilled because her personal situation has changed. We've helped her learn how to plan her meals on a budget, and she's employed, and so she's able to fulfill that issue and is no longer food insecure. So that's just one example of many, but really trying to figure out how we can replicate that. And I think the importance of studies like the one that we're involved in with Joe and others is really about how do we get that external objective look at the data, because I think it was noted by Jeff maybe earlier, we know healthy food is good and it's the right thing to do and it should lead to better health. But there's a lot of scrutiny around programs like this, and I think even more of an expectation that you demonstrate the ROI and using these types of RCTs and other external organizations to help us do that, I think is critical.
Great, thank you so much. That was a wonderful overview of the program and super exciting what you guys are doing. We're going to pivot over now to Joe Doyle. Joe, you're going to give us an overview about the research design and maybe some of the nuts and bolts about how the on the ground the study is run.
Sure, yeah, thanks Jeff, and thanks Allison. Thanks John for being here as well. This is an extremely inspiring program, so it's been really fun for me to talk with people who are running the program, go visit, speak with clients, and it's I'm really excited about this project. So one thing, what do the researchers bring? So we do bring expertise in terms of how to analyze data, and as being economists, we bring an economics framework where we're modeling this behavior as the program is lowering the cost of healthier behaviors, and so that inspires how we run the experiment and what do we measure to see what works and why it might work. So, for example, there's is it the food delivery delivery that's driving improvements? Is it the increase in education? So we have both clinical data from electronic health records and claims data, as well as survey data that we're going to use to try to unpack any mechanisms that might lead to improvements. So we're going to learn for people who understand more about their disease. Are they the ones where we might see bigger impacts, or those that switch from going to fast food 4 times a week to going to 1 time a week? Are those the people that we see the improvement? So we're going to try to those will be more speculative, but I think it's important to get there. In fact, meeting with people, the nurses on the ground actually thought that one of the main reasons why the program is successful is that it improves the self-efficacy of the clients. So now, instead of going to the corner store to buy a sandwich, they're cooking for themselves. They're learning how to do so. So when I said it lowers the cost of eating healthier or behaving healthier, both in terms of providing the food, but also the know-how of how to prepare that food in a tasty way. So yes, so that inspired us to add questions to our survey of trying to measure the self-efficacy of the clients. So how do we go about doing it? And maybe some in the audience, if you want to partner with JPAL to think about intervening for social determinants, the way we did it in this program is that they were planning an expansion of the program. They were rolling out into 2 new cities, Scranton, where I happen to be from, and Lewistown, Pennsylvania, and as Allison was saying. And so we were able to randomize, instead of opening the door and allowing everyone in on day 1, which wasn't really feasible, we're randomly assigning people who are eligible to the program to either start now or they're going to start in 6 months. So it's a waitlist design, which has its own issues, and we do think about how to deal with those. But we're going to see in the historical data that A1C, the blood sugar levels, improved over those first 6 months and then sort of plateaued. So we're going to be able to capture people in the program for 6 months versus no months and sort of summarize all of that. And then we're going to interview people later as well. So you'll have some people will be in the program for 12 months versus 6 months. We also think a lot about how to manage. Some people engage fully with the program, some people less so. So we'll be using statistics to try to adjust the estimates to take into account that this less than full engagement with the program, which is as expected. So I want to keep my remarks brief so we can get to other people and to their questions, but essentially I see this as an amazing opportunity to test an inspiring idea that food is medicine, and education about people's diseases and improving their self-efficacy. Does that improve their health and ideally lower healthcare costs? Because if that's the case, I think programs like this would really take off. And ultimately, that's what we're trying to do, build an evidence base for what works and what doesn't, so that other payers and providers will be clamoring for programs like this one.
Great, Joe. Thank you so much. I think what we all want to know is, are you eating healthier and exercising?
I was, and then the pandemic did hurt my exercise. My tennis playing definitely suffered for that, but that's right. Whenever we have a lunch talk to discuss these programs, we make sure we have a healthy lunch. That's for sure.
We're going to keep you out of the random group then. So Allison, would love to have you give us an introduction about RIP medical debt. This is a really cool project, so excited to have you give folks an overview. Allison Sesso.
Hi, thank you so much for having me. And yes, I would say I had to adjust myself during pandemic too. I got myself a spin bike and did a lot of home cooking, but it took a little while. So RIP Medical Debt is a nonprofit organization that's focused on abolishing medical debt across the United States. It's a very unique model. There's no one else out there like us. We sort of combine the generosity of donors, and we leverage their donations, and we go to the debt market, and we actually buy medical debt for pennies on the dollar, because of the fact that those we're focused on are low income. Our qualifications in order to get your debt relieved are that you have to be 200% of poverty or below. The debt has to be 5% of your income or more, or you have to be insolvent. So that's what we do. We were founded by two debt buyers who actually decided to sort of use their knowledge of the debt market for abolishment purposes. And so once we negotiate with either a secondary debt buyer or with a hospital directly, we pay for the debt, and we take title to that debt, and then we just send letters out to the individuals and say, we alleviated your debt, you no longer owe this debt, and you're free and clear. And we know that medical debt is a social determinant of health, but we don't know, it's like what I said, and what we do sounds great. I mean, donors are clearly inspired. We got a $50 million grant from McKinsey Scott recently. I mean, this idea of medical debt truly resonates, and the funds are coming in. But the issue is, we don't know. We want to make sure that what we're doing is actually having an impact, and to what extent. And luckily, this research project was going on before I walked in the door, which was about 15 months ago. And what we're really trying to understand is, whether or not this medical debt relief makes a difference for people, both in terms of their access to borrowing, as well as, their overall well-being. And so that's who we are and what we're focused on. My vision for the organization, we have to date abolished $4 billion of debt, which is pretty significant. But the size of medical debt is so much bigger than that. So if you compare it to what's out there, it's really not as significant as I'd hope. What's nice is that we've helped relieve debt for 2.3 million people. And to me, frankly, like, that's the better measure. It's not the amount of money, but the number of people that we've touched. So I was, again, thrilled to walk in the door and have this analysis going on. And I will absolutely let Ray talk more about how it came to be, because I wasn't here for that to happen. But I do want to say something important from my perspective. Who I am and my career has really been focused on public policy, right? The systemic problem. Like, medical debt is a systems problem. It's to me the result of I wouldn't say a broken healthcare system. I mean, look at what everyone's just talked about. The healthcare system is serving people well. It's the healthcare financing system that's broken. How we finance healthcare is more of the problem. But then on the other end, we also have a broken economic system. The number of people living paycheck to paycheck and not being able to pay even the deductible for their health insurance plans is growing. So I just want to say that the reason why I'm really interested in this research is to be able to speak to the larger problem of medical debt, so that we can point back to the systemic causes of it and hopefully do something there. Because while I love what I do every day, I'm simultaneously appalled that this work is needed in the world, and I hope to really put myself out of business. And so I really want to leverage what we do to better understand the implications of medical debt, so that it's better paid attention to, and also clean up the medical debt that's out there, but ultimately to make sure that we stop, go upstream and stop the problem from the beginning. So I'll stop there, and that's it. Thank you.
Allison, thank you. I had in my head pictured you cold knocking with a big giant cardboard check, but a letter seems appropriate. Ray, we're going to pivot over to you, like Joe, to talk about the research design for this project.
That sounds great. So thanks so much, Jeff, and thanks, Allison. So we've been thrilled to work with RIP over the last kind of 4 or 5 years of their remarkable growth. This project actually started at a JPAL HCDI conference, I think 4 or 5 years ago, when we invited Craig and Jerry, the kind of original RIP founders, to a JPAL conference. So this is joint work with Neil Mahoney at Stanford, Wes Yin at UCLA, and Francis Wong, who's a postdoc at NBER. So as a research team, there were a few reasons that we were really excited about working with RIP. And first is that medical debt is just really hard to study. So definitionally, it comes along with a negative health shock. It comes along with an inability to work often and a kind of regression in earnings, which makes it really hard to isolate the impact of the kind of debt aspects of our healthcare system. And second, we saw this as a terrific opportunity for an RCT, right? And so, forgiving debt is hard, it's expensive, you need connections that, researchers don't have. So being able to work with RIP and their kind of existing connections with the debt buyer industry was amazing. And, was able to kind of make all of this possible. And third, we kind of saw this as an ideal context for a randomized evaluation. So kind of you can think of fertile ground for an evaluation as anywhere where there are kind of more people than you can help who need it. And so here, randomization is just a fair way to allocate the benefits that RIP is doing, while also having this benefit of allowing us to evaluate their practices and figure out kind of what the effects of what they're doing are. So as far as the research project, we have a few different objectives. So our first objective kind of gets to some of the latter things that Allison was saying, and that's kind of demonstrating the size of the problem of medical debt. So, 1 in 5 individuals has a medical debt in collections on their credit report. And so, as a kind of first step in this, we want to, establish the size and the scope of this problem. And then second, as we get into this randomized evaluation, and as Allison said, these kind of numbers are pretty mind-boggling in terms of the number of people that they're helping. And we've been able to randomize a fair share of that debt forgiveness. So, we're focused on 2 different types of outcomes, I suppose. So the first are these kind of financial outcomes, the kind of things that you could see on a credit report. So understanding the financial consequences of this debt going on your credit report, or being relieved by RIP, and as part of their practices, they have that removed from the credit report. So that'll be able to kind of enable us to understand the impacts on their ability to borrow, people's ability to buy a car, ability to buy a house, kind of general kind of financial well-being. But beyond that, this is a kind of social determinants panel. And so one of the things that we're really interested in that I think researchers have had a really hard time studying is the kind of non-financial consequences of debt. So these are kind of often overlooked, but they include things like kind of, how does debt affect your mental health or stress, depression and anxiety? How does it affect your physical health? And then how does it affect your interactions with the healthcare system? So how likely are you to kind of go out and get insurance after having your debt relieved or not? How does it affect your kind of drug adherence to your prescriptions, your healthcare utilization? And so, able to see all of these outcomes, we actually needed to roll out this big survey. And so as part of our work with JPEL, we've been working on with NORC, the National Opinion Research Center, to scale up this really big survey of folks who have had their debt forgiven in the treatment group and folks who did not in the control group. And this allows us to get at a lot of these kind of less salient, but potentially more important measures of the effects of medical debt. So, as I mentioned before, like our goal of this is to understand the scale of the problem, the effects that medical debt relief and the effects of medical debt sent to collections have on patients. And then, as a final point is to, help RIP figure out where they can have the biggest impact. I think one thing that goes overlooked with RCTs is often that a program may not be kind of successful on average, but it may be successful for some patients and not others. So one of the things that we're looking at for RIPs, medical debts forgiveness, is figuring out how they can target that debt forgiveness to have the biggest benefit, whether that's kind of buying debt as soon as the hospitalization happens, or buying debt kind of down the road with patients who have been struggling with this debt for a few years. And a side benefit of this is that we can help hospitals and kind of healthcare delivery networks target their own charity care policies. So figuring out, who is really going to be harmed by this debt, and can I help my CFO factor that into this, charity care decision beyond kind of what is their ability to pay. So a lot of our work is just kind of focused on this kind of global picture of the effects of medical debt and how that kind of filters through the rest of the healthcare system. But yeah, we've been kind of thrilled to have the opportunity to work with RIP and JPEL, and we've certainly been inspired by Jeff's work and some of the other projects that have been discussed here today.
Great, thank you. So I want to take two tacks in our kind of discussion here. One, I want to go conceptual about, why RCTs and sort of at that level, and then we'll get tactical about some of the details of running this. So let's frame it this way. There is an RCT that looked at arthroscopy, which is a bread and butter knee procedure to scope your knee. And the RCT showed that it had no impact for most people. We do 650,000 arthroscopies a year still, despite the RCT results. Medicare pays a lot of money for it. So we're doing something completely ineffective and paying a lot of money for it. So I want to ask the program leads, there are a whole lot of things that in society that we pay a lot of money for, even though we know they don't work. Why are you holding yourself up to such a high bar of an RCT? Why not just go out, produce a nice PDF that says your program's amazing, throw some stats out there and claim success? You're holding yourself to a really high ethical bar, programmatic bar, societal bar, intellectual bars. So maybe first to the Geisinger folks, Dr. Bulcher and Allison, some thoughts on that.
Sure. I think it's twofold. I think one, because it's the right thing to do for the people we're serving, and we really want to. We have finite resources, and we really want to make sure we're using those resources in the right way. And if it's not helping, we could use those resources to do something else that does help. I think the second piece is it's a little bit around resource utilization as well, because understanding exactly what the secret sauce is around the program allows us to focus those resources, and then allows us to potentially bring the program to more people, because we're now able to focus resources instead of doing everything on a per patient basis, if you want to think about it that way. So it's really, I think we look at it as a way of, we believe this works. Let's prove that it works, and let's prove what is actually working with it. So then we could say, yes, one, it's a right place to put our resources, and two, we can use those resources to bring that to as many people as we can.
Great, thank you. Allison Hess, want to give you a chance if you have some thoughts on that.
No, I agree with John. I think that's the piece of it. And I think the other thing too is, it goes back to my earlier comment about just having kind of that objective partner. And I would argue that we're probably, as an organization, our own worst enemy. I mean, we really drill into data and kind of pick it apart for that reason. But I think it just brings an extra level, when you engage in this type of research and study, that just adds that additional validity to the programs that you were doing. And again, everything John mentioned is right on point.
Yep, that's great. Allison Sesso, let's pivot over to you. Some thoughts about that.
Yeah, I mean, I want to know that what I'm doing is making a difference, right? I want to know that I'm not wasting my donors' money. I think that there's a responsibility there that's really I take very seriously. There's a lot of different causes, and nonprofits vie for limited philanthropic resources in general. And I think that if what one organization is doing doesn't work, then you should make sure that those donated dollars are going to an organization that is doing something that works. I also think that given the size of the problem of medical debt, that it's almost like I want to make sure that it's so vast. I want to make sure that I'm putting the resources where they're most effective, because there's just so many people we could just go out there and blanketly get rid of medical debt, but with limited resources overall, and given the size of the problem, I think we really do want to target to make sure that we're at least first prioritizing where it's going to matter most. And then the other thing I think about this is what I said towards the end of my comments, which is understanding who it matters to more can have bigger implications for our understanding of this problem, and bigger different solutions than just mine. So I would see that's really why I think this is absolutely critical. And I'm mission driven. I'm not margin driven as an institution. So at the end of the day, that's what this is about. It's about solving the problem. And I love the idea of that Ray mentioned a little bit earlier, that part of what we do is help when hospitals engage with us, they can reflect on their financial assistance programs and make improvements right in that moment. And that really helps go again upstream and reduces how much debt I need to take care of.
I think something you said and Ray said is incredibly important, this idea that it may not work for everyone. There may be people who subsets that it works on, and ultimately RCTs can lead you to refine your model in that direction. So I think sometimes we hold this bar up that it's, either it works or doesn't work. It's far more subtle and complex than that. And it's a continuous process of learning. So cancer trials, it wasn't like, sorry, it didn't work, you're all going to die, we're done, we're packing up. It's been years and years and years and years of continuous refinement, learning, RCT after RCT after RCT. So it's an ecosystem of learning. So I want to pivot down to the tactical for a second and imagine there's a newbie in the audience. They've got a model they think works. They're terrified of the idea of an RCT, and they can't imagine, adding another hour to their day or another need to raise funds or anything like that. So maybe back over to the Geisinger folks and just talk a little bit about the sort of resources. You guys are a very large organization, but you don't have infinite resources. What's it been like to set this up? What's the collaboration like? What's the delegation of duties? And what could a newbie expect?
Go ahead, Allison.
Yeah, so from our perspective, I think the team that we worked with MIT, they were instrumental early on with really laying out the expectations, what our responsibilities were going to be as part of the process. Again, going into it, what resources we were going to be expected to be able to provide, and also helping to secure funding or giving some suggestions for how we could go about that. I think those were really critical pieces for us. They truly have been a partner in this. And as we've hit roadblocks along the way or barriers or things have come up, they've been an incredible resource just for us to be able to bounce ideas off of, or if we have to, adjust things. Again, speaking from a resource perspective, they've given us some suggestions for things that have worked in other organizations and other areas. So, I have to admit, going into it, I was a little bit concerned. We were a pretty strapped team. We were running pretty lean as it was. And on top of it, a healthcare organization during COVID, I think it's safe to say anybody in that space is strapped. And so really concerned about how that was going to potentially impact our ability to continue moving the study forward and successfully be able to do that. And I just think the team just has been a great resource for us. And so I do truly feel like it's a partnership, and they've helped us identify, again, very clear expectations, and it's been spot on through the process. They certainly have done this before, and that's been really helpful.
Yeah, and I just would add, I think the collaboration is key. We do a lot of work at Geisinger where we're studying things and certainly consider ourselves a learning organization. But this has been, and Joe spoke to it a little bit about how you're thinking about study design and how we're thinking about this is there's kind of a wait list part of it, and how to really actually, I think first in the beginning, it was really brainstorming and saying, how do we answer these questions we want to answer beyond just, well, it looks like it works, and you have a pre and post that looks like it works, and a whole bunch of anecdotes that looks like it works. How do we really study this, and then how do we get down into the detail? We wouldn't really be able to do that without the collaboration. And I think to your question, Jeff, it did kind of, it was kind of making our heads explode thinking about how the heck we're going to do this, and the kind of light bulb is, geez, let's find someone to collaborate with. And it's been really a wonderful collaboration because we've thought of things with the program that we would have never thought of. I think it's added things to the program that we would have never done. And I think no matter what the result ends up being, we'll be much better for it, and our patients will be better for it.
Jeff, you're on mute.
Thanks. I was so good. I made it all the way through without doing that. Allison, have you talk a little bit about the tactical and what it's been like to roll this out and do this?
Yeah, so again, the beauty for me is I walked in the door and this is already underway. You know, I guess as a coming a new executive director, I could have said, oh, it's not worth our time, but I had the exact opposite reaction. I mean, again, coming from a background of I took this role because I thought there's bigger public policy implications and learnings here that we can influence. I mean, having research that was already underway was, in my mind, saved me time. It was a shortcut. So I was thrilled, and it's been a great relationship. I mean, honestly, I don't see any of it as additional burden. I believe me, I totally appreciate the idea of like, I can't do one more thing on my plate. But to me, this is so valuable, and it gives us credibility. I will tell you, almost every conversation with donors and with my board, getting new board members attracted, it gives you a huge amount of credibility that you're willing to take this leap. And that you're looking at yourself in the mirror. So that I would say is like worth a lot. And I mean, actually in dollars. And then the other thing is, you know, it really strategically is going to give me some guidance here. You know, it's going to help me make decisions down the road. And I'm thrilled for that. I think it's going to help us, you know, I'm going to take a media opportunity to make sure that we leverage this and talk about what we do. I mean, so to me, there's so many benefits to doing this work. And in terms of the actual level of work, I actually see it as shortcuts to other goals. And I don't see it as a burden at all. I see it as a huge priority.
That's great, Allison, thank you. So we have about a minute and a half left. So we're going to do a quick round robin here back to Joe and Ray. And the question I want to ask you is really about the heterogeneity of results, talking a little bit more about sort of how you think about RCTs and this sort of continuous model learning, kind of where their place is. Joe, do you want to kick off sort of where the place of an RCT is in kind of continuous learning and solving problems?
Sure. I mean, whether working with you, Jeff, or with the Geisinger team, they're, you know, you're data-driven organizations. And what does that mean? Well, it means that you follow the data and where gathering insights from that to improve your product. And so that's not as an overall what happens on average, but you want to see who the program works for and who it doesn't. Now, in a relatively smaller scale RCT, we're going to get hints of that. And ideally, we would push on that as we get insights to have another round of learning. And I think maybe Ray can talk about a broader trial gives you the potential to do that even more finely within the first round. But what do you say, Ray?
Yeah, so I mean, the class I teach with my MBAs is entrepreneurship, and that's all about hypothesis-driven management. And so when you're setting your strategy, you have some set of beliefs about the world, and your job as a manager of any organization is to test those hypotheses and kind of set the strategy appropriately. Obviously, you know, working with RIP is amazing because they're kind of constantly buying new debt and new portfolios from different parts of the country and different ages of debt and different debt collectors. And so, you know, this will give us a rich sense of heterogeneity that we'll hopefully be able to work off of and kind of help them kind of develop their own strategies and hospitals to develop theirs as well. But, you know, in general, I kind of view any business process as this kind of hypothesis-driven learning process. And so making those hypotheses explicit and testing them, you know, with kind of JPAL's backing and the kind of rigorous RCT methodology is, I think, you know, the best way forward for a lot of these problems, you know, where that's feasible.
Great. Thank you, everyone. So we're going to promise Hannah we would end on time, and we are on time and on schedule. So thank you, everyone. Thanks to the panel, and thank you for the amazing work you guys are all doing and sharing it with us today. So